Hi everyone and welcome back to another episode of GP Notebook TV. Lisa Devine is my name and I'm a GP in Wicklow in the Republic of Ireland. Today I'm going to talk you through some interesting practice points from a section of the recent American Diabetes Association 2025 update on the management of diabetes, and this particular chapter relates to the management of diabetes in older adults. So diabetes care is certainly not a one-size-fits-all approach, and being able to tailor management to what really makes individual differences to our heterogeneous group of older adults is very worthwhile in my opinion. I often find myself wondering when I do consultations with older adults living with complex diabetes, how is their age impacting and interacting with their diabetes? And how is their diabetes impacting with their health as an older adult? And could this missing information unlock the value in this consultation with the older adult sitting in front of me? In the update from the American Diabetes Association, they have adapted the 4Ms framework for age-friendly healthcare that's being adopted by many healthcare systems looking after older adults, and in this case they have applied it to having the chronic disease of diabetes. Now, the 4Ms, if you're not familiar with them, are number 1, mentation, aka mental activity or thinking. The second is medication. The third M is mobility, and the fourth M is what matters most to the person sitting in front of you. Their use of the framework is something that really clicked with me, I have to say, and I thought it would make a great in-consultation tool. So let's have a look at how each individual M impacts on a person who has diabetes who is of older age. So when it comes to mentation, having diabetes increases the risk of a person developing dementia of any kind. And having episodes of both hypo and hyperglycemia can increase the risk of cognitive impairment. This guidance also describes a new phenomenon which is really interesting, that of a diabetes-related dementia, so a very specific form of dementia. This is a condition characterised by a slowly progressing form of dementia, often seen in people with a longer duration of diabetes, people who maybe have a higher likelihood of insulin use, people who have elevated HbA1c levels, and also have sarcopenia and loss of muscle strength, and an absence of any other particular neuroimaging findings in other types of dementia. The other topic when it comes to mentation, of course, is mental health, and we know that anxiety, depression and diabetes distress are also more prevalent in older adults living with diabetes. Struggling with challenges relating to mentation also impacts on how a person can self-manage their diabetes, leading to challenges such as self-administration of medications, difficulties in their ability to use diabetes-related technology, for example, check their capillary glucose, or look after their everyday activities of daily living. And I suppose what this says to me is it makes identifying difficulties in mood or cognitive function a key area to consider if we have a person living with diabetes and they're a little bit older and everything seems to be going wrong for them. The second M to look at is that of medication. And the guidance asks us to remember the treatment burden that our patients are living under. Older adults living with diabetes are at a higher risk of polypharmacy, and where patients also have cognitive or functional impairments, special care is needed in prescribing medications to make sure that these medication plans are tailored to the individual's own characteristics, or their access to support from family or carers to help them follow through on the treatment plans we put to them. Intensive glycemic regimes, in particular those involving insulin or sulfonylureas, can pose particular challenges, and also risks of hypoglycemia, which is a real risk. And with hypoglycemia, we see increased risks of hospitalisation and mortality. The guidance asks us to consider two key principles that we should keep in mind when prescribing in older adults with type 2 diabetes, and I suppose these are really common sense things. The first is to select medications with a low risk of hypoglycemia in older adults with type 2 diabetes, and especially those slightly frailer adults with other risk factors for hypoglycemia. The second suggestion is that we avoid overtreatment where possible and simplify or de-intensify medication regimes where the harms and burdens of treatments are greater than the benefits. Now, in a second video on this topic, we'll cover a little bit on individualising treatment targets for older adults with diabetes, which can also help us in avoiding over-treatment of our older adults. So on to the third M now, which is for mobility. And I suppose the standards of care reminds us that older adults living with diabetes are at higher risks of frailty, sarcopenia, leg weakness, neuropathy, foot ulceration and reduced functional ability compared to those older adults living without diabetes. It also suggests that in addressing these factors through appropriate acknowledgement of them, advice on nutrition, exercise and multidisciplinary team input, we can really improve the day-to-day health and quality of life of our patients. The last and perhaps most important M is what matters most, and I think this is much more important than box ticking or target hitting. Suggested topics from the guideline which could unlock problem solving and an efficient consultation, and a consultation which is really useful to our patients, involves getting a better idea of the person's own goals and expectations, trying to understand their day-to-day symptoms and their day-to-day disease burden, as well as their meal and treatment preferences. For example, how do they feel about injections and glucose monitoring? And also whether loneliness and social isolation are affecting their health. So there you have it, a brief review on the 4 M's as they apply to managing type 2 diabetes from the recently updated standards of care for diabetes in older adults. I have to say, this guideline has a huge amount in it and is definitely worth a read if you have the time, as it's full of practice-changing insights. I couldn't fit them all into one video, so I do look forward to making another video for you on their approach to glycemic and other target setting in older adults. I look forward to seeing you again soon on GP Notebook TV.